Chair calls Gerry Purcell. What we'll do is we'll get on a little quicker pace, but we don't have 40 witnesses, but we still have about 6 that we have to work through.
Thank you, Madam Chair.
State your name for the record, who you're with, and your position on the bill.
Gerry Purcell. My company is Pharmacy Partners. I'm here today representing the Texas Pharmacy Business Council. It is a pleasure to be here, Madam Chair and members of the committee. I flew in from Atlanta specifically for this hearing today. I'm here to offer my unqualified support for Representative Brown's amendment and keeping control over the vendor drug program at the state level. I want to offer you 4 quick points today. I won't spend a lot of time on the premium tax. I do want to say a few things about it because I've spent a lot of time in Georgia talking about it. We also have a premium tax in Georgia. I would just say, and this is the space that I operate in the marketplace, primarily representing large payer plans, taxpayer plans, and providers, and protecting their interests. I will say we have taken up the issue of the premium tax in Georgia. There's been 2 really thoughts about it. Number one, a lot of our citizens did not know that there was a premium tax in Georgia because it's buried in the premium. Over the last 12 to 18 months, we have had a campaign, literally, where thousands of Georgians have been educated on the premium tax. And I can tell you, ours is quite high. It's about 4.7%. It's higher than Texas, but we do share half of it back to the counties and the cities. But when our citizens have found out about the premium tax, they're not happy about it because every expert that I have talked to all agree that premium taxes raise the cost of health care. So, because you're adding that to the premium cost. The second thing is our legislature understands, I believe, that the sustainability of the premium tax is in question. In fact, the White House, this is hot off the press today, this is from the White House, the framework would clamp down on states' use of provider taxes, same thing as a premium tax, to lower their own spending while not providing additional health services through Medicaid. Representative Ryan has called these premium taxes or provider taxes a skewed political incentive that raises the cost of health care and raises the cost of Medicaid. So to put reliance on future dollars and to make future dollar commitments in a program where the sustainability is in question is concerning. And I would just caution you to take a real close look at that because over time, ultimately, I do believe premium taxes are going to go away. In Georgia, we first have eliminated premium taxes on health savings accounts. That's our movement towards getting rid of the premium tax altogether because both our citizens and our legislature understand now that premium tax raises the cost of health care. And in this case, it's contemplated that $51 million will be raised in new premium taxes. And ladies and gentlemen, these are not savings. These are taxes. That's what they are. They're premium taxes. The second point I want to make is this notion that Texas needs a managed care approach to save money. I would submit to you today that Texas already has a managed care approach to your vendor drug program. In fact, and I hope you realize this already, but Texas is considered by other states, which I'm out and about in the entire country, as one of the leading innovators in Medicaid pharmacy programs in the country. You have been for 2 decades. And I would just give you, and in fact, I agree with Mr. Vasquez. There's a letter where he states that the current program has been very effective in the past at managing costs and ensuring clients' access to services. I agree. It has been one of the most effective. And I'll quote a couple things real quick. You have a 1% administration fee to manage your drug program. $28 million. Dr. Perryman just mentioned that Pennsylvania, when you extrapolate the number, it's $66 million. I would submit to you, in my experience with PBMs, you are not going to get an administrative fee less than 5%. And I would say it's going to be between 5 and 10%. So your $28 million that you're currently enjoying, again, one of the most innovative in the country, is going to go away. You're going to blow through that number when you add not only the MCO as a middleman, but you add a second middleman on top of the MCO who's a subcontractor to help manage the program. The common formulary that you have is very good. The common appeals process. Imagine having patients all over Texas, and let's say you have 8 to 12 new MCOs and new PBMs. You're going to have a dozen different appeals processes the citizens of the state of Texas, Medicaid recipients, will have to go through potentially a different one depending on the PBM. You have near total transparency now. And Madam Chair, you mentioned the curtain. You're about to raise the curtain again. Right now, you have almost complete transparency on your program. If the state auditor wants to come in and audit your vended drug program, no problem. I can assure you, because I've done dozens of these audits, including the CalPERS one that's in the news now a good bit lately, and others with 14 attorneys generals. You're going to have significant challenges in trying to audit the PBM relationship. We'll talk about that real quick in a minute. The final point on this whole managed care approach, you have one of the most unique pricing programs in the country. And I don't know if you realize this, but we just heard pharma come up and say $1.88 that is what they're seeing on dispensing fees. In Texas is $7.35. Wow, isn't Texas out of proportion?
$7.53.
It's actually $7.35, Madam Chair. There's some things that go into that bump it up, which some of these guys can explain, but it's apples and oranges comparison. That $1.88 that pharma talked about is based on average wholesale price. Cost, wholesale cost, and average cost. There's 3 levels in between. The $7.35 that you have is based on estimated cost. You are buying your drugs at the retail level for cost. There's only 2 other states in the country that have that enviable program. Alabama just moved to that. Oregon has been on it a long time. And you're going to have states all over the country that are going to try to do what you're doing. In fact, it's a topic of discussion. This is one of the few industries, the pharmacy industry in Texas, that doesn't get to mark up their product. They don't charge a margin on top of it. They charge cost, and then they get an administrative fee. So I would like to ask pharma, and I won't do this, I apologize, but would they be willing to sell their product, would they be willing to sell Lipitor at its cost to the citizens of Texas? And then we'll throw in $7.35 as an admin fee to help cover their margin. Of course not. They wouldn't be willing to do that. If you're in the retail business, you wouldn't be willing to sell your products at cost plus, probably. But yet that's what the pharmacists in Texas do, and that's one of the reasons why it makes Texas one of the most innovative programs. And I'll give you some statistics on that.
And we're going to pick up the pace.
You bet. Madam Chair, I'm trying to talk very fast.
But you're all excited, and I love it.
Well, I'm passionate about this.
Keeping us awake.
And I don't want Texas to lose money.
Right.
I want you to save millions of dollars.
I'm fired up.
The fact that the notion that MCOs can handle generics better than you are already handling it at the state level. Let me share a couple of facts. The generic dispensing rate is, we've heard, Madam Chair, members of the committee, 72%. The big 3 PBMs, the group that you contend or contemplate turning over your Medicaid lives to, you know what their book of business generic dispensing rate is? 72%.
Huh.
And an even more telling figure is in the mail order environment, because that's where the PBM owns the prescription. They become the retailer. Their mail order dispensing rate for generics, 61.5%. We're going to go from 72%, and we're going to turn it over to the PBMs, who in the most controlled area they have, the best they can do is 61%. I'm not sure that's a good idea. The average generic price in the United States is $35. The average generic price in Texas VDP is $24. You're leading the way. Now, the point is we need to make it better because we've got to save some money for the state. The fact is, though, you're beating their pants off right now. You've got a great program, but we can make it better. Now, here's the thing. We're never going to have a 100% generic program. So I know some of you have concerns about, you can't anyway, because only about 80% of the drugs have generic equivalents anyway. And we can construct it in a way so that the doctor still prescribes what the doctor wants to prescribe. The reimbursement is set at the generic rate. If there's a prior authorization, that could be contemplated to make sure that the patient gets the brand if that's what's medically necessary. You can do that. The NCOs, I think, have come to the state and they've said they can achieve 80%, even though I think the state's talking about 3 or 4%. You are 27th in terms of your ranking now on generic dispensing rate. 27th. Hawaii is number one with close to 80%. I'm talking to MCOs all over the country, big ones, over 1 million lives, that are telling me that they're not only going to achieve 80%, but over a couple of years, and this is a biennium bill, it's not going to happen overnight, that they will achieve 83 to 85%. So what I'm suggesting is that the 10% is very doable. And I mean, we do have $200 billion worth of generic drugs going on. I do want to answer one question about brand drugs, Madam Chair, that you asked, where you think the price goes up. One specific example would be Lipitor, which is going off patent this year, November. The price has gone up 16% prior to the patent conversion. So you're absolutely correct. It's another one of those funny games that are played where you raise the price, rebates, look better, everything looks better, except for you end up paying more money. So the GDR, the generic dispensing rate, is going to go up anyway. It's just by default. We can help accelerate that, and I think even HHSC has stated that for every 1%, you get $11.4 million improvement. So you may get 4. I think you can get a lot better than that. What if you blow through 10? And most states are going to blow through 10. Then you're up into the $150 to $200 million savings just by simply doing a few things, but still allowing the patient and the doctor relationship to continue as it should. And the last point I will make has to do with just basic concerns about PBM practices in general. And I know it sounds like a broken record when we talk about PBM litigation. The problem is that the PBMs keep putting the record back on the phonograph. We have litigation because of practices, and we are approaching $1 billion in litigation and settlement events in the PBM industry. Now, the problem with a construct that's contemplating of turning this over is that when the Attorney General or the Texas State Auditor goes to audit the PBM contract, guess what he's going to find in between? A managed care company. So managed care company signs a private contract with the PBM. You have just made it very, very difficult to get beyond that barrier. In fact, it's why the state of New Jersey decided to do the same thing, basically, to take that contract away from the MCO and to go direct to the PBM with a contract. It's why Ohio did what they decided to do, take control back. It's why Pennsylvania decided to do what they did, to take control back. And let me close.
Let's wrap it up, and we'll see if there's any questions.
You bet. In 2007, we had a generic swing of 10 percentage points in pricing. Guess what happened to the plans that were locked in to their PBM in 2007? They were stuck with their reimbursement rates for 3 to 5 years because they couldn't go back in and renegotiate those contracts. You don't have that problem since you control the vendor drug program. When price changes occur, and I'll submit to you that we've got the generic pricing market is going to be crazy. Imagine a $194 drug going to $24 and the savings that you can derive from doing it. It's going to be crazy over the next few years. You don't want to lock in with a PBM contract. You want HHSC to have the discretion to change those actual cost numbers on a daily basis and to adjust those fluctuations. And they are going to, they're going to come. Control over your formula, that's already been talked about. The use of AWP, I would not allow a PBM to use AWP in any taxpayer plan in this state. AWP, commonly referred to as ain't what's paid. You want what you have, an estimated cost program or a wholesale acquisition cost program, plus a fair dispensing fee. So that the farm, because that's where he's going to, that's the only place he or she has, to make their margin. The necessity of audits, let me just, you know what an audit cost of a plan this size? $300,000 to $400,000. Now all of a sudden you might have 8 to 12 different vendors. How are you going to audit them? Are you going to spend $150,000 to $200,000 to audit every single one of them? So your audit costs are going to go up. Now the Texas auditor can just go in, and having access to those contracts again is going to be difficult. Your appeals.
Your last point is.
My last point is, Madam Chair. My last point is, don't fix what's not broke. Don't break it. You've got a great program. Go for the changes that are the generic programs. Improve the brand or lower the brand dispensing a little bit. Improve the generic dispensing program. Yeah. Put some clinical programs in as contemplated by Representative Brown's bill. Do those things. You can get $100 to $200 million in savings. Thank you, Madam